Welcome to the ICU podcast, where we explore the vestibular experience through conversations between patients and the health professionals who care for them.
During this podcast, we invite patients to share their stories and healthcare professionals to ask questions so they are equipped to better care for and truly see the invisible challenges faced by their patients. I'm Kimberly Warner.
And I'm Cynthia Ryan, and we are your hosts on this journey of discovery. Welcome, everyone, to another episode of the ICU podcast. Today, we're going to talk about persistent postural perceptual dizziness. I have to say that really slowly because it is a total mouthful. It is no wonder we actually call it triple PD or PPPD. This is a relatively new vestibular diagnosis that helps explain why some people continue to experience vestibular symptoms when test results are actually normal. Triple PD typically starts shortly after an event that causes acute vertigo, dizziness, or some other disruption of balance, but it may also occur for unknown reasons, have no really known cause. Triple PD causes dizziness without vertigo and fluctuating unsteadiness that's provoked by environmental or social stimuli such as crowded places. A lot of triple PD patients have a really tough time with places like grocery stores and malls. Some critics question whether this is a, quote, garbage diagnosis for people with unexplained vestibular-like symptoms. In a separate interview that is available on VIDA's YouTube channel with Professor Jon Stone, we learned that this is not the case, and indeed triple PD can coexist with other vestibular disorders. So today we're going to talk with a patient who struggles with triple PD and a physical therapist who treats this complex condition.
So our first guest, our patient guest, who is actually quite accomplished professional as well. Her name is Susan Blount. Welcome, Susan.
Blount.
Susan is a college professor, publishing and media executive, and certified health and wellness coach who has dedicated her career to education and well-being. After developing PPPD following a trip to Alaska, she faced life-changing challenges. Yet, through vestibular rehab, cognitive behavioral therapy, and a commitment to strength training, she has redefined what it means to live fully. Now, Susan empowers others with the message that being both healthy and chronically ill is possible. I love that. With the support of VIDA community, she continues to navigate life with resilience, purpose, and joy. We're so happy to have you here with us, Susan.
Thank you. I'm glad to be here.
We also have today with us Dr. Megan Daly, who is an experienced vestibular physical therapist and a health coach. Megan has her own physical therapy and coaching practice that helps people address the root causes of their symptoms and navigate the healthcare system and modify their lifestyle. She also runs Dizzy Coaches, a vestibular mentoring program for clinicians of all levels. She helps patients with dizziness, migraines, concussions, and balance issues manage their conditions so that they can have fewer dizzy days. And she herself has experienced many vestibular conditions personally, and she brings this empathy to all of her patient interactions. Welcome, Megan. Thanks for being here today.
Thank you so much. I'm so happy to be here.
So, as we usually do, let's begin with a little nutshell storytelling. Susan, we'd love to hear about your vestibular journey and then how you came to be diagnosed with triple PD.
Okay, great. It's hard to do it in a nutshell. I told my husband when I was talking about it, there's so many parts of everyone's vestibular journey that it's hard to make it short. I think, what happened was I got an upper respiratory infection that caused me to lose the hearing in my left ear. And what was so confusing about it is that was in April, but I didn't actually become dizzy until July. And so in the beginning, they kept thinking somehow those things were connected, but we were on a trip to Alaska. I had already been dealing with the hearing loss in my ear and thought everything was back to normal, other than the fact I couldn't hear, and was now wearing a hearing aid. And on the flight on the way home, I had this very strange, it was like electrical impulses from the side of my face, down my neck, down my arm. And my husband called the stewardess. They thought, was I having a stroke? They couldn't understand what was going on. And that was on a Friday. And by the time the plane landed, I seemed to be okay again. And the paramedics came and everything seemed okay. Like I just had some kind of a weird thing that happened, but everything was fine. And the next day I was okay. And my husband woke up with COVID that day. And then on Sunday, I woke up and I couldn't raise my head. That it was, I first had vertigo and the room was spinning and spinning and spinning, and I was vomiting. And because my husband was so sick with COVID, it was several days before either one of us could really do anything about how sick either one of us was. So Thursday of that week, he took me to the emergency, and I had to go in a wheelchair. I couldn't even walk. And I'm a runner, I'm a tennis player, I'm a very active person. So to not be able to walk is a pretty extra, and vomiting. And when I went in, they told me that it appeared that I had, like on the side of my face, like maybe I had shingles or something, which none of us had seen because I'd been too sick and I was covered in vomit and my husband was too sick. But they didn't itch. You really couldn't see them. And no blood tests were taken. So some of the things that could have been done then in the emergency room were not done. And so I went on Monday to see, back to the ENT who'd been dealing with my ear to try to understand what was going on. And he could see that there were some lesions on the inside of my ear, but they already seemed to be getting better. And of course, he signed me right up immediately for physical therapy, for vestibular therapy. So I started immediately. He first did some kinds of steroid shots into my ear to see if there was inflammation. But what we found is that was I wrote some of these dates down because it's hard to remember. That was in July. But I did speech therapy because I had so much brain fog and was struggling so much to remember. So I did speech therapy. I did vestibular therapy. I started on a low dose of Zoloft. So they were doing and I had every test, as most everyone does, known to man. And there was, they didn't understand why I was still sick because, as we know, everything looked normal except for it wasn't. And I was having trouble. I couldn't read because my eyes couldn't follow. I couldn't think. So I couldn't work. My family, I couldn't go anywhere with my family because the noises were too loud. I lived downtown in Fort Lauderdale, which is very busy. And we walk everywhere, and I couldn't walk across the street without, all of the vestibular movement. And my husband is a pastor. We have a very progressive church with a lot of lighting and production and sound, which I love. But I was not able to. The sound, the lights, the movements, the people was just too much. And I was kind of thinking about a year into this, I thought if you do everything you're supposed to do, I really thought at 1 year I would suddenly feel better. And 1 year came and I still felt the same. And so I had been many years to the Mayo Clinic in Rochester for executive physicals. And so I contacted my doctor there and I said that I had been reading that they had a dizzy and balance center and could I come? And he required that I first come and do the whole physical first so that they could rule out what it wasn't before I went to the dizzy center. And they did tell me when I went in to not expect to get an answer, that dizziness, especially now that I was dealing with it for over a year, 24/7, that dizziness is sometimes a mystery, and sometimes you get an answer and sometimes you don't, which wasn't very encouraging. But at the end, they came and they had this brochure and they said, we think we know what it is, and that it's 3PD. And I had actually, at the conference, I had actually watched someone. I think one of the reasons that Vita has meant so much to me is that I went in March and I had just been to the Vita conference before. And one of the sessions I took there was someone who talked about 3PD. And as I heard it, I thought, the anxiety piece made a lot of sense to me. I thought I could really see that that could be something that I could have. But what I really learned was how it talked about making a list of questions to ask to different doctors because of what their lane is. And so I went to the Mayo Clinic very prepared to ask questions of the right doctors because I had been to the conference. And that was, I think, still to this day, that's been one of the most profound sessions I've ever seen, was knowing what doctor to ask what questions of and what language to use when you ask them, because I really didn't have the words to explain what had happened to me. And I knew a lot of people who'd been dizzy for a day or two, but no one dizzy, over a year, 24/7, and not being able to find your way through it. So I was able to get in March of 2023 is when I got I got a diagnosis, and I immediately, everything I read about it, I thought, yes, I absolutely see that it just described everything I was going through so well.
Wow. Susan, I'm just so touched, and it makes me so, well, I'm smiling over here because I love hearing your story about how the VITA conference helped you be prepared to go see your doctor. We're right now, we are in day one of this year's VITA conference, and it's just, I know how important it is to provide patients with information so that they can be their best health advocate, and it's just great to hear that has worked for you. So thank you for sharing that.
I didn't have any language for what I was experiencing, and it was the first time I realized there was a language that could describe this that I really had I didn't know before.
Yeah, absolutely. So Megan, we there is a lot of confusion about what triple PD is and how it's differentiated from other vestibular disorders. We just heard from Susan how her doctors were very clear about that they had to rule out other disorders before they could rule triple PD in. Can you explain that a little bit and help us understand how triple PD is different from other disorders? And I'll just add in there also if people can have triple PD and another vestibular disorder.
Mm-hmm. Yeah, that's a great point, is that with the work that I do, I rarely see just one vestibular condition by itself. That's an ideal day. We have one thing happening, but oftentimes there's layers of vestibular issues that are happening. So someone could have BPPV. They may also have a labyrinthitis, which is turned into a hypofunction. And then maybe there is some 3PD on top of that too. So it's very common that there's more than one thing happening at a time, which can make it harder to diagnose. And I think that's why that's such a key piece of the diagnostic criteria put out by the Bronte Society, is that at the very end of the diagnosis, it says, unless accounted for by another diagnosis. So it's a exclusion one where we have to kind of rule everything out, and looking at the symptoms and the subjective history and the amazing description that Susan just gave is really important part of our intake and our history, because it is a non-specific dizziness. It's a non-spinning vertigo, and it's happening all of the time, which will differentiate it from a lot of different things. So if we look at the BPPV, the classic BPPV profile is that it's a very intense spinning vertigo. So right there's a differentiation between a non-spinning vertigo and an intense spinning vertigo. And then looking at the time frame of that too, with BPPV, it usually lasts for a minute or less. And then the symptoms either shift so that you feel kind of nauseous and off for a little bit, or it just completely stops, versus the 3PD, it just continues and it's persistent, right? It just continues throughout the day. There's no relief, there's no change. It may wax or wane, but it doesn't have that intense defined stopping point like BPPV will. And so then we start to look at, well, do we compare this to something more persistent like vestibular migraine or Meniere's disease? But even looking at those, they are very cyclical. So people will get this unexplained dizziness with vestibular migraine, and it may last for 2, 3, or 4 days, but then it can go away and it can clear out, which is different from the waxing and waning of the persistent 3PD. And there's a similar profile with Meniere's disease, where you have these intense flare-ups, these intense episodes, but then they will go away again, and then they will come back again. So I think looking at that, looking at the time frames, looking at the descriptions, looking at how the symptoms change, help us differentiate this from other vestibular issues.
Can I add in because I had a physical therapist that was arguing around my diagnosis, which was mal debarquement, but there's the spontaneous category, and they were saying, no, it's not possible. It has to be PPPD because the spontaneous thing isn't real. But unlike, and maybe I'm incorrect, but unlike triple PD patients, mine goes away when I'm in passive motion. Is that your distinguishing factor between spontaneous mal debarquement and triple PD?
Yeah, that's what I would say. For mal debarquement, we see that patients get relief when they're in motion, and their symptoms go away. It's when they stop moving that they feel worse. Versus 3PD, you could be sitting and doing nothing, and you have these persistent symptoms. So yeah, you're absolutely correct, Kimberly.
Interesting.
But someone could, for example, have vestibular migraine and triple PD, correct? And I would imagine that it's very difficult to differentiate those and be able to put both labels on and then treat them separately. Probably there's a lot of overlap to how they're treated, though.
Correct. Yeah, that's where it gets really interesting, is teasing those things out. And that usually takes longer than just the initial assessment session. It depends on how they're responding to treatment, right? I find that as we go through the assessment, and we may spread that out over a few sessions too, because of the sensitivity and the provocation of symptoms. So as we try some treatments and we continue to work together and pick up patterns and tease things out, it definitely takes longer to figure out, okay, maybe we've got layers of things happening here. You know, in the initial assessment, it's all going to show up as a central vertigo. Vestibular migraine is coming from the brain, 3PD is coming from the brain. So we're going to get those central signs with our assessment. But it's really the patient's response to treatment and continuing to sort of journal their symptoms and their patterns and their responses to our treatment that's going to help us tease things out. But like you said, there is a lot of overlap. So that's the nice thing, is we can start the treatment and we're sort of treating both at the same time, while then maybe adjusting a little bit to address things that are still flared after the 4th or 5th session versus things that have really responded well to the treatment.
Wow. And before we move on, I just want to include one other category, if you will, or diagnosis, because Susan, you mentioned hypofunction. So you were talking, Megan, about central and peripheral disorders and disorders where you have spinning vertigo versus ongoing dizziness. Whereas with hypofunction, which means there's no function in the inner ear, it's a peripheral disorder, you don't have vertigo or dizziness. You just have imbalance, lack of balance, right?
Yeah, it depends on the hypofunction. So hypofunction can also be just less function. So there's varying percentages. If there is no function, then there is an imbalance. So some people do not get any vertigo. But if there is some function, it just depends on how big the disconnect is between the right and the left ear. And that will determine how much vertigo you may feel. So that symptom pattern can vary a lot with hypofunction too.
Susan, I saw you nodding your head when Megan was talking about the persistence of triple PD. Can you tell us a little bit more about your everyday symptoms? I'm assuming persistence is a part of that.
I'm dizzy all the time. And so I think that, I I think that a couple of things have really helped me with that. And of course, the CBT is big, but neuroplasticity, labeling things what they are. I also think that there's one of the things that that I found in that second year after I finally had a diagnosis was I went to the University of Miami, and I'm over 230 or something on the waiting list, and they had a person there who did functional physical therapy. And so what I kept thinking was, if I could be strong again, if I could, because there's about the being unbalanced and the not hearing and the trying to be so cautious and careful, I had lost a lot of my strength. And so I felt like that one of the keys was to be able to do some of the things, the exercise and the physical things that I had done in the past. And so finding that when I finally got the call that it was my day, and I thought, I don't know what I have to do. If I have to go on a boat to get there, I'm going to get there. But to be able to go, and she's the first person who really looked at me, and she said, "What was your dream?" And I said, my dream is to be able to play tennis with my grandkids again. And she tossed me a tennis ball. And of course, I'm like trying to find it. And she said, "We can help you." She said, you can do this again. And it was really the first person who was helping me to envision a different future than the present I was living in. And I think I really focus so much on, I think I had to learn how to not wake up and say, "Am I dizzy today?" Because in the beginning, I would wake up and think, "Oh, it's still there." And so I really had to move beyond that and not think about being dizzy, but think about being healthy and happy and finding a way to navigate those things so that I could live my life again, whatever that was going to mean. And so it meant a lot of changes to my life, but I still had my bucket list and all the things I wanted to do. And I have four amazing grandkids who I love being with them so much. And my goal was really to be able to, wake up at the morning and realize, okay, there it is, but here I am, and really make that move. I told my husband once, we were talking about this, about how, you can think there it is, and instead of leaning into the dizzy, you move away from it. And I said, I don't know if I would have ever understood that before I experienced it, of acknowledging it's there, but not allowing it to take over. And that real purpose of focusing on, so what's on my list today? What do I need to do? I get, I get really tired. I have times where I have a lot of word retrieval or brain fog. And so I've had to learn how to say no, and had to realize that self-care is not just me care, it's care for those around me. And that if I can be my best and say no to things that I know are going to be more difficult for me, or things that are going to take a longer period of time to recover from, I get to say more yeses. And so it's just trying to navigate those. And I really consider it, I asked my husband, even getting ready to talk about this, am I better? It'll make me cry. I asked him, am I better? He said he didn't think I was better, that I was the same dizzy, but that I navigated, and each day, he said, I moved through it. He said in the beginning it was a wall, that I would come up against it, and he could see if we were out walking and there was a loud noise or a smell, or a car drove too fast, and so all of a sudden I would lose my balance and start to fall. And he said he watches me now that he knows, he watches me sometimes when I have to ground myself in a situation where it's too loud or too noisy or too many people. But those things have just become a part of what I do. I don't focus on them. I realize when I'm going in somewhere, oh, this sounds a little bit loud. And, I keep things with me that help me. I have earplugs, I have other kinds of things that help it so that I can still participate. But I always have to measure, is there going to be a great recovery period of time? How much am I going to have to sleep if I do this? Because it wearies my body. I'm very attention deficit, and that was always my secret sauce. And one of the things I don't seem to be anymore is attention deficit. And I miss that secret sauce. It's like part of my brain that was always figuring things out is now helping me to not fall down and keeping me not dizzy. And so my brain is still doing a lot of things, but it can still only do so many things at one time.
Yeah. That's really interesting. It's you can't control your environment or things that are happening to you, but you can control your reaction to it.
Yes, exactly.
And that
Exactly.
sounds like very much part of a mindfulness
Mm-hmm.
practice.
Mm-hmm.
Wow, very interesting. Now, Megan, I know that you have some
Yeah.
personal experience with vestibular migraine and concussion. How's that informed your approach to creating treatment plans for other vestibular patients?
Mm-hmm. One of the big things that I got out of being a patient while also being a provider is that less is more. Less can be so much better. And when you get out of school, you're so motivated to help people and you just want to give them all your knowledge and all of the tools so that they can feel better. But I think it's common for a lot of these central issues like vestibular migraine and 3PD that we tend to overdose and overtreat. So finding that proper dosage and even going less than that can be hard as a clinician because you feel like you're not doing enough for your patient. Really, you want to help your patient as best you can, but to take that step back and meet them where they are with their symptoms and really have a good system for tracking that so that they don't come out of vestibular rehab and say, wow, that made me so much worse. I don't ever want to do that again. It was terrible, right? We've all had that experience, or I've heard that from patients. I've heard that from clinicians. And that was something that was really driven home for me experiencing it, is that you want to find that happy medium place where you've got a little bit of symptoms so you get that good brain learning, but then you implement the rest strategies and you space things out and pace things appropriately. So that would,
Really,
yeah.
when you said dosing and and pacing things appropriately, because I think that's really key. I think and last year there was also, in one of the conferences talked about dosing, and I think it's the dosing of physical exercise, the dosing of how much can you have, how much can you do it, how much can you even learn about vestibular issues, and really knowing in between those things you have to have those periods of rest. That's so good.
Yeah, and the dosing, even as far as like what you were saying, Susan, about not waking up and going, is it a dizzy day, but having other things to focus on. Dosing, even in the approach that we all take towards our own healing, and just letting ourselves be for a while and focus elsewhere. I think the dosing has to happen even down to our treatment plan and how much we actually pursue each week or month or year.
Mm-hmm.
Susan, we've talked about, I actually had goosebumps when you were talking about some of your coping strategies, and I can relate so much. I want to know a little bit about what medical treatments were prescribed when you were diagnosed with triple PD.
So they prescribed, of course, Zoloft, and then CBT, the cognitive behavioral therapy, and then vestibular therapy. And so those were really the three main things that they described. And I committed to do the Zoloft for 1 year. And when I didn't, because I was thinking there maybe was an easier way. If I could figure this out, if I could somehow use mindfulness or some of these other things, maybe I wouldn't need it. And so at the end of 1 year, I quit that. What I currently do, which is working for me, is I take a very small dose of Xanax in the morning. It's 0.25. It's very small. And so when I take that and I use my morning walk, I consider that part of my medicine. I first thing I do when I hit the ground, and I have to walk not windy like this. I need to walk where I can see long in the distance. So I have a couple walks that I do in the morning that I consider part of my medicine because they help me to focus far. I used to do them and do my eyes and do all kinds of exercises. And now I find it's just better for me to just do them and breathe. And so I just start my day by having that period of time where where I walk and I breathe and I drink water and just get ready to start my day. But those were, so really, I think that I was fortunate that they kind of gave me this three-legged stool, and to start with just one medication, and then the vestibular therapy and the cognitive therapy. And the cognitive therapy I really think has really helped, because I really needed to learn skills to change the way that I was talking about things to myself and the things that I was saying. I really needed a new voice inside my head.
I love the way you put that. Needed a voice inside your head, and it sounds like that. That does sound like the typical approach to triple PD: the medication, cognitive behavioral therapy, and vestibular rehab. And then we'll talk more about lifestyle changes on top of that. Megan, when a triple PD patient comes to you for physical therapy, they've generally been referred by a medical doctor of some sort. Is that correct? What types of healthcare professionals might they have seen before they reach you, and what kinds of treatment might they already be using that you then help them, by adding on the vestibular rehab part of it?
Yes. I think that some patients can take a very scenic route through the medical system trying to get the 3PD diagnosis. They typically will start with their primary care doctor, who may send them to ENT or neurology or both for assessments. And because of that non-specific dizziness, they also may see a cardiologist to make sure there's nothing wrong with the heart or any of the vascular systems. Sometimes they'll also see endocrinology to assess those systems as well. And along that journey, they may be getting meclizine to address the dizziness. They may be getting other medications for anxiety. They might be getting things that, if they have additional heart issues, maybe that's found at the time, or they are put on a specific diet to see if that changes anything. They might monitor electrolytes. They might have dietary consults. And sometimes they may also see alternative providers too. I think it depends regionally. Some places are more focused on that. And so people may come in from an acupuncturist or after they've tried different types of therapies and they're still experiencing symptoms. So that's typically when they'll come to vestibular therapy.
The end of the road, so to speak.
And do you typically, Megan, try to encourage them to continue some of those modalities, or how do you coordinate with the practitioners?
Yeah, I think vestibular rehab is definitely a team approach. So we're always working with all of the different providers to optimize the outcome for the patient. And I always want to work in the patient's best interest. So if they are focused on the treatments that are working really well, I want them to continue doing those. If they find that they're not as aligned with certain systems, whether it's conventional or alternative, I am going to support those choices as well and see who we can find to support what they want and what they need for their therapies to complement the vestibular rehab as well.
That's great. Oh man, it's so heartening to hear valuable practitioners out there in this community, because I know so many of us have had some not so helpful ones. So let's go a little bit. Susan, you've talked about some of the strategies you've worked with, and you've already covered some really important ones, even the walking in the morning and not focusing on the dizziness and changing how you talk to yourself. Are there any other lifestyle changes that you've done to cope?
Well, I think sometimes it's hard to remember what those are. I think my life has completely changed. Mm-hmm. And, even when I try to prepare in a different way than I used to, like knowing when I'm going into a situation. I was much more of being attention deficit. I just kind of took each day as it came, and I can't do that anymore. I really have to plan ahead and think through if there might be some issues where I'm going to go. Am I prepared? I do have some of the things I've forgotten is I do have the prisms in my glasses. I have a hearing aid. And when I was getting ready to teach, because now I'm teaching organizational leadership on the college level, and I didn't know how I was going to be able to do that, like walk and move and think and talk. Like I was trying to figure out how am I going to do all of these things at one time. And the vestibular therapist was so good. We really worked on on that. Like she would ask me questions while she was having me do things, so that I was having to think. I gave her the outline for the first few classes, and then she would like talk with me like she was in the class with me while I was doing all kinds of different vestibular exercises. So I was moving my head, I was talking, so that I could feel more confident when I went into it, and not suddenly have, I always call like a swish moment, where all of a sudden I lose that moment and I find I'm out of focus, or I have to suddenly not feel dizzy. And so I think what I have to do with my life is just prepare more than I used to, and think about more of those things. I eat really healthy. I get good sleep. I don't spend a lot of time on my device. And I think that I don't spend a lot of time thinking about, why did this happen to me? And some of the people who started out with me that I met in vestibular therapy and other things along the way, would try it, and they got a little irritated with me about a year and a half into it, because they would say, "Oh yeah, we know you're not trying to figure out why this happened to you anymore." And I said, "Well, it's not that I'm not trying to figure out why this happened to me. I'm just trying to figure out, how do I live now? And if I keep focusing on how did this happen to me and why, then I'm going to miss the life that's for me still to live." And so it isn't that it isn't that I don't think about having a vestibular disorder. It isn't that I don't think about being dizzy. I find that when I focus more on living my life, that um, the dizzy is there. And if I'm still, and I mean, I told my husband, it's so crazy. It's like it cannot be there, but if I'm still, and just for a few moments, I focus on what am I feeling, it just all comes in. But when I'm focusing on my life and how to live my life and what we have to do, and even when I first started CrossFit, it's just really fast, and I thought, I'm going to fall down and kill myself. And my husband just watched he thought, how is she going to do this? But once I speed up and start focusing on the future, on a specific task, I found I could push the dizzy farther away while I'm focusing on the task. And so I think I've just really trained myself to look away from it. And
sorry to interrupt. I just, you're reminding me of one of the guests talked about what you're saying here. And how the focusing on it can sometimes increase the dizziness. And she actually explained it because when we are focusing on those symptoms, the brain actually is perceiving that we are in danger still.
yes.
And so as long as, our brain is going, oh, she's focusing on this, so it's important and we must be in danger, it keeps that, sympathetic state up, it keeps the anxiety up. And so I thought that was such a helpful way to frame it. And it makes so much sense.
Someone once talked with me, they were explaining to me, like, when you're in a tractor and you're going on a muddy road and you keep going down that road and going down that road and going down, and you keep making those ruts deeper and deeper and deeper, that it's harder to find a new road. And that really made a lot of sense to me. I'm not a farmer, but it still made sense to me. If I keep going there, I'm training my brain to go there, that I've just got to focus on that the sky is, it's beautiful outside today, that these are the things I have to do, that, and even sometimes stopping and feeling the breeze on my face, like and just being more cognizant and aware of living life and envisioning a forward life instead of a dizzy life.
Yeah, beautiful.
So you were talking, Susan, about how your physical therapist helped you. And so Megan, I'm curious, could you explain to us how vestibular rehab works for triple PD? I mean, what is it doing? What is it doing to our brains? And how does that make us feel better?
Yeah, there's a couple of things to focus on with 3PD. The first one is habituation. So that's that slow exposure, right? That's where the dosing comes in. It's very important to have the dosing there, where you're gradually exposing yourself to these movements, like Susan was doing, getting ready to teach. So she was going to have to move around, and we wouldn't start with the full lecture or the full amount of time, right? We would break that down into pieces and see how she responds, monitor her response to that, to keep her within that happy symptom window, right? Where it's not too much and it's not too little. and continue to increase that as she tolerates that, to teach the nervous system that these movements are okay, that they are safe, that we want to keep exposing ourselves, because if we stop and do nothing, then it can actually get worse.
Mm-hmm.
And another piece of it, as Susan highlighted too, which is fantastic, I love hearing all these stories of patients' treatments, was to make it meaningful to patients, right? So if someone gets a lot of symptoms when they're moving around, say they're bending over to pick something up off the ground, right? They're cleaning the house, they're putting laundry in. That's not the most exciting thing, right? And I can make that an exercise in the clinic by having them pick up a pen, 5 times until they start to feel those symptoms. But again, that's not very exciting, right? So changing that to something that's meaningful, like maybe you're bending over to talk to your grandchild or give them a toy, or you have a pet and you're giving them a treat. We would use that as the treatment versus just bending over and doing that over and over again. So making it specific, like playing tennis, you want to get back to that, bring your tennis racket into the clinic. Let's do some tennis in the hallway versus, okay, I'm just going to have you turn side to side, quarter turns over and over. So making that really meaningful to the patient. I find
that's so cool.
it's so important.
Yeah, and I imagine, so it also means that you have to spend more time just in dialogue with your patients so you can learn about those things, which helps put them at ease and makes, builds the rapport between you two. So it's brilliant.
Yeah. Yeah. And then we could be here for 2 hours if you want me to keep talking about treatments, but a lot of it looks at also specifically weighting the sensory system, right? So we have three balance senses that we're working with. We've got vision, we've got the vestibular, which is the head movement, and then we've got that body sense, all of those touch sensors and somatosensory input. And so with 3PD, there's too much vestibular happening. Your body just keeps playing that tape over and over and over again. And so when I look at challenging my patients, but keeping them in that nice window where it's not too much and not too little, I will normally take away 2 of the senses to isolate the sense that needs more training. But with 3PD, we're going to back that up. And so I'm going to give them 2 of those senses to work with. And then I'm going to just modify that third sense instead of completely taking it away. So I am constantly playing with this balanced triangle of senses. It's almost like a soundboard where you're playing with the controls, turning things up, turning things down to continue to challenge that entire balance system and how the brain is processing all of that movement.
Wow.
That's good.
That's so fascinating. I want to hear all of them. It's brilliant. Do you have one more that you wanted to share? I mean, we have time.
Okay, great. Yeah. So a lot of it is also looking at that visual input too, right? Because a lot of visual movement will exacerbate symptoms and make them worse. So testing that out and seeing, that's where we can also differentiate sometimes. Some central disorders have more issues with movement, like they're riding in a car, with motion sensitivity. That can be more irritating versus going to the grocery store and having all of that visual information and all of that color and the fluorescent lighting and things like that. So we'll work on the visual stimulation as well and add those pieces in gradually too, so that again, there is that habituation. And we look at their entire environment. How is their home environment? How is their office environment, right? Are they always under fluorescent lighting? Is that exacerbating things? Can we switch that so that we can turn the fluorescence off and have softer lighting in the room? We'll put softer lighting in the clinic. We'll start with maybe wearing a hat to go to the grocery store or to go to Costco, so that you're blocking out some of that light, you're blocking out some of that overwhelming vision so that the nervous system can feel more safe and become more accustomed to these movements and these environments that you want to go out and do things day to day.
And I'll just add in there, you were talking about, adding things in slowly, adding stimulation in slowly, but not avoiding.
Mm-hmm.
Right. So many people say, well, I just can't do that. So you're not saying don't do those things. You want to get people used to doing those things in a controlled way.
Mm-hmm. Right. Like how can we modify it so that you can do maybe tiny little bit of it to start.
Mm-hmm.
Do you ever go on field trips with your patients?
Yeah.
I'm almost imagining that, like, sometimes walking to the grocery store with them. And
Yes.
do you do that outside of the clinic?
Yeah, it's one of my favorite things to do because you really get a sense of how people are responding, right? It's one thing to challenge them and see how they respond in the clinic, but to actually see them doing things in real life gives you even more information. So yeah, I've taken patients out on hikes and they're like, this is when my symptoms happen. And I'm like, oh, I know exactly what you're experiencing here, and we can work on this, or the grocery store or an exercise class, things like that.
Wow, that's so helpful. Susan, let's go back to some of the issues that people have around this diagnosis. I'd love to hear what you would say to people now on the other side of being through the diagnostic phase and a lot of treatments. What would you say to the people that question the usefulness of this diagnosis?
I guess I think I'm fairly I think I'm lucky in the fact that I read it and it made sense to me, and that I didn't have an issue with the anxiety piece of it. I'm a very hard driving type A person. It made perfect sense to me that that would be part of it. And as time has gone on, I can measure, in the past 6 months, my dad has died. My mom lost her house from a hurricane, and then she broke her shoulder. And I could feel I could feel that I was having to wear my weighted vest more, that I was having to do more grounding things. And so, which again, once again, was telling me the validity of the diagnosis, that when I put myself in those situations, and that it's worse and it's harder for me to navigate them, and I have to do more to counter the amount of dizziness that I'm feeling. But I also think that if I know that it's important to know what your diagnosis is. Sometimes it's important to know that to be able to get the right kind of treatment. Sometimes it's important to know that for yourself. Just you yourself your emotions or whatever need to know what your diagnosis is. I think sometimes it's more important to move past that and find a vestibular therapist like Megan, or someone who can help you move through them and how to live on a daily basis. What are the tools you're going to need to navigate your life now? And I think that we at times get so caught up in what our diagnosis is, and we think this is the box then that has to fit in. One of the things that always causes me to hesitate when people ask me about why I'm dizzy specifically, or they tell me that they have something, or they tell me all of these stories, is everyone is so different in how they respond to what their dizziness is, that what works for one doesn't always work for another. And so which is the most difficult thing, is to find a great team. You really know someone who can do like what Megan is saying and try things with you and lean into them and pull back and see. So it could be that I have other diagnosis with it. I just know that at some point, the moving forward was the most important thing, and the understanding this is how I mentally, physically, emotionally respond to what's happened to my life, and what do I have to do to navigate those things to be happy and to live a full life. And so I think we get so caught up in what is it that I have and how did this happen to me, that we forget that we have to live now, and how do we move forward. I don't know if that's a good answer or not.
Excellent answer.
When I hear someone call it a garbage diagnosis, I think, well, you've just never been dizzy.
Yeah.
Yeah. I think all the time people will tell me, I'll go and I'll sit in Sunday school and someone will say, oh, I was dizzy this week. And I think, okay. People tell me, gosh, I know you say you're dizzy, but you look good. And I was thinking, looking good and being dizzy are really not the same thing. I just think that the resilience and the learning, the mindfulness, I just think some of those pieces have been, without those pieces, I don't know if the vestibular therapy would have helped me as much, because I don't think I could have let down some of my fear to do what I was being asked to do. and lean into it. And so, so for me, what's worked best is not to concentrate as much on what the diagnosis is, but what do I have to do now to live this way?
Yeah.
Thank you for that. Absolutely. So, Megan, how about from a clinical perspective? What would you say to people who question the usefulness of this diagnosis or think it is, as I'm using air quotes, a garbage diagnosis for any type of unexplained dizziness where tests are normal?
I typically would start with more questions. I want to know more about where that's coming from for them. What is their perspective on that? What is their background? What is their knowledge? Is this a clinician saying this, and what's their background there? What kind of perspective do they have on this? Maybe they've been dealing with this with a partner, a spouse, a friend, or something, and they're frustrated, and it's coming from a place of emotion for them rather than really experiencing a positive result from this, and they're just venting. It depends really, because I feel like vestibular disorders in general can come under that blanket a lot of times, not just 3PD, but anything vestibular and dizziness related can get easily dismissed and shoved aside. So those conversations, I think, need to go deeper into where that person is coming from and get a sense of what they're aware of. Maybe they need some more information. Maybe they've got a personal experience that they're reacting to, and then we can have a deeper dialogue about it.
Yeah. It's a great answer. I'll just add a little bit more from people that I've heard who have given me feedback. I think that some people feel that because this is a new diagnosis and it's one of those a diagnosis of exclusion to some extent, that doctors, and I think that we're talking about doctors who are not vestibular specialists, will sometimes, when the tests come back negative and they've ruled everything else out and they have nothing else to say to the patient, will just say, oh, well, then you must have triple PD. I think that that's where some of the frustration comes from, is for when that happens. And I think that the other part of it is some people, Susan, you were saying that you don't mind the anxiety part of this doesn't bother you, but I think it does bother some people.
Yes.
Patients sometimes feel like by giving them a triple PD diagnosis, what the medical community is saying is that it's all in your head. It's not what the diagnosis is, but that is how some people feel about it.
Yeah. I think that's a really good distinction, Cynthia. And I would say, after doing the Life Rebalance Chronicles and working with all those lovely humans, anxiety is a part of a vestibular disorder. It doesn't mean it's caused it. It might be symptomatic of a type of nervous system that has some sort of propensity towards it, or it might just be there exaggerating what's happening already. But it's quite impossible to not feel anxious when the world is moving around you all the time. Yeah.
And Susan, I think you said it really well. You said that being aware of your anxiety helps you to work with it.
Yeah. Mm-hmm. Yeah.
So,
do both of you have any last words of wisdom to the community? You have so much wisdom to offer here, so I want to tap that resource.
I think for me, I just think that it's the focusing not on what you've lost. I think there's a grieving that comes to being chronically ill, of any way you're ill, but chronically dizzy. There's a grieving of the things you can't do anymore in the way you did them before, and in the things you've lost, because even when I'm looking at my clothes and the kind of life, I traveled all the time, and all the things and traveling is just not a healthy thing for me. And so when I think of the way I have to live now, there's a grieving and a loss. And I think you really have to kind of move through those stages so that you can let go what was and really focus on, so who am I now? And how do I be happy and healthy now? And I think an unusual thing for me is there's some about the person I am now I actually like better. I think under the way I think, the way I understand the difference of people's journeys, the way I have to process, the way I have to be present, I think there's some about me, even though I still feel a loss, there's some about me that I like better who I am now. And I wouldn't say it's a gift. I wouldn't want to be dizzy, but I would say there's always a next. There's always a new. If you can quit looking behind, and so and and I don't say that easily. My life has completely changed, and there's been an enormous amount of loss. But there's been new things and new people I've met, new things I know, and I think there's a lot about me that's a stronger person than who I was before.
Wow.
So
So
well put.
beautifully stated.
Yeah, it's extremely well stated, Susan. I really love that because that grieving process is a huge part of this. And I think that can be it's
okay. Mm-hmm.
It's so hard. From a clinician standpoint, I would say for someone that has not yet been diagnosed or is still looking for answers, there is help. There is hope. There are people that can guide you through this process. And it's not an easy journey, as Susan has given us an amazing story. And it's not a quick journey. It's definitely time consuming, but there are so many avenues for support out there and clinicians and resources. And Vita does a great job with the education and the support groups and all of the other committees that are working to help people. So you're not alone if you're experiencing this. You're not isolated. There's, I often hear one of the two things that I hear the most as a clinician from my patients. Number one is that they were told there's nothing else that they can do for what they're experiencing. And then after we have our first session and I give them education about the balance system and how everything works and what we're seeing with their assessment, they always express hope, that now they have hope because they have more information. They understand we may not completely get rid of it, we may not cure it, but there are ways to go forward and manage their life and get back to the activities that they love to do.
It's good.
Wonderful messages. Absolutely. The message, it's interesting that when we get to the end of each podcast, this is where we usually come to, is that there is hope. And there's a three-pronged approach, which is educating yourself, getting connected to a qualified healthcare professional, and getting connected to a peer support network. So I hope that everyone listening feels some hope wherever you are in your vestibular journey, and that if you need help, that Vita is there and has resources that can help you. So thank you, Susan. Thank you, Megan, for sharing experience and expertise. Another wonderful episode of ICU. Thank you all.
Thank you.
Thank you.
Thanks for tuning in to ICU this month.
We hope this conversation sparked new understanding of the vestibular journey. And for all of our patients out there, leaves you feeling just a little more heard and a little more seen. I see you.